So hi, and welcome to this interview that I'm having with continuing conversation is what it is, John, with Dr. John Lumpkin, former state health officer for the state of Illinois with an illustrious career since then. We're going to have a chance to learn a lot about that and his definitions of success for state health officers, because this is part of a series of interviews that we're doing for the University of Indiana Fairbanks School of Public Health about public health leadership and success and the ingredients that make it so. This is a Du Beaumont-sponsored project. We thank Du Beaumont for that, and an ASTHO-supported project as well. We couldn't do it without ASTHO. And of course, we couldn't do it without state public health leaders like you, John. Thank you for joining me today.
Great. Thank you. It's a pleasure to be here.
So, John, this is a study of success factors for state public health officers. So let's just start at the beginning with, what's your definition of success as a state health officer? What is that?
I think success of a public health officer at the state level is threefold. To the extent that they create the conditions in which local public health can be successful. Health and public health occurs at the local level, where people live, learn, work, and play. And the state health agency's job, primary job, is to make sure that that happens at the local level. And that could occur through working through local health agencies or through direct action by the state health agency itself. The second measure of success is to the extent in which the broader health context is addressed. And that means initially working with other state agencies whose primary purpose may not be health, but who have a direct impact upon the health of the people of that state. That includes the Department of Education, the Department of Transportation, as well as others that are more likely suspects like Human Services. And then the third measure of success is the extent in which the public health director, the public health official, improves the functioning of their agency through adoption of quality improvement methods, through the focus on innovation, and a persistence focus upon the workforce to help improve the qualifications and capacity of that workforce to be able to carry out our continuing public health mission.
I love that answer, and it doesn't surprise me a bit that given all the leadership of yours over the years subsequently as well, that you'd come down there. Help people who are particularly new in state public health to understand the ingredients of that success. What does it take within the agency or the context to create the success that you talked about?
Well, it's critical for the public health official, the lead public health official of the state, to be the health leader. And that means not just coming up with great ideas, that's important, but also interfacing and working with the people throughout the state who are engaged in that. So first, measure of success, creating the conditions in which local public health agencies can be successful. That means working with public health directors. That means working with individual communities. And so just focusing on what happens at the state capitol or within the offices of the public health agency isn't enough. It means building that network. Sometimes it means interfacing. During my career, we had at some point a major schism between small local health departments and the larger local health departments. And it probably wouldn't surprise you that the biggest heart of that was about money. Where were the resources going? And it's important for a public health director, for an agency lead, to understand not only the conditions in urban communities, but also the conditions in rural communities. Because we find as a nation, if we want to improve health, we have to reduce disparities. And the disparities that exist within urban communities are equally as great as the disparities that exist between urban and rural. The second area of success in the skill that's required is reaching out to other agencies and other forces. And that means understanding the importance of coalitions, what they now call collective action, of bringing together unusual suspects, unusual bedfellows, people who don't normally work together. And for that, let me give an example of what I think may be the biggest improvement that we can do in health as a nation. And it's surprising to come from somebody in public health, but I would say that that could be something like universal pre-K. You know, you just sort of follow the logic chain through. Children who participate in pre-K have better social emotional skills. That always makes them better citizens. But they're also more likely to finish high school. And at age 25, someone who has not finished high school, when you compare them to somebody who's graduated from college, the difference in life expectancy is 9 years. So when you think about an intervention that could have an impact of 9 years of life expectancy, you got to talk to the folks in education. And public health leaders need to see that broader context and bring people into the room, not to do public health work, not to bring them in the room and talk about restaurant inspections, but to talk about how if they do their job related to enhancing education, it has an impact upon health. How transportation and the ability of people to get to appointments, to be able to work, has an impact upon health. And all of those within that broad concept is what a public health leader, the health leader for the state, that's how they can have an impact. Now, the third area that I talked about is building the agency. We live in a time where, the best days for funding for public health agencies may be behind us. And we could do one of two things. We could lament the fact that we're not, our budgets aren't as big as they have been, certainly if you figure out in present dollars. Or we can figure out how to deliver public health services with the resources that we have. There's an assumption that because we've always done it this way, that means that's the most effective and efficient way. I think we have to get into the modern era and think about comparative effectiveness of public health interventions, of increasing the effectiveness and efficiency of the use of public health dollars. And if we do that, we can enhance the functioning of our agency. And we also need to think about our personnel. We need individuals. We need to build partners with the schools of public health so that the graduates from schools of public health actually think about going into governmental public health. And we need to think about ways to hire them, because too many of those graduates who have the skills we need leave school and they can't find a job. So developing that linkage, again, is how you build the public health workforce within your agency.
Great and specific, and I thank you. Let's get even more specific. Remind us what years you were in service as a state health officer. When were you a state health officer?
I was first appointed in 1990, and I left in 2003.
And during that time, let's just talk about, you had so many challenges. Just name one issue that was among the most challenging, most exciting that you had to confront, and talk about leadership lessons you learned in confronting it. Would you just give us a specific of your experience as a SHO?
My guess would be is that every state health official who was a state health official in 2001 would say that the events that happened on September 11th and actually subsequently in October with anthrax was a wake-up moment. And for me, it really was a culmination of work that we had begun in the agency many years prior to that. And it was a sort of a validation of an approach. It was our major challenge. It's hard to describe the environment when those first anthrax cases were reported, where we were getting calls from daycare centers. They were talking about, we've discovered a white powder by the changing table. Well, was anybody using baby powder? Someone got a letter full of white powder, and we said, where did it come from? Well, it came from my daughter. Did you ask her if she sent it? Oh. And when we went back, yes, she actually thought I didn't have any baking powder, so she sent the recipe with the baking powder in the envelope. There was a mass hysteria around this. But part of what our response was building upon the partnerships that we had built. Partnerships with the state police who worked very closely with us around all the reports of white powder so that our laboratories were not overwhelmed. The ability of our laboratories to do the kinds of molecular biology to test whether or not these samples actually might have anthrax. All of that was based upon prior work. And the ability to work with our emergency management agency. And that all was put in place, our ability to respond to this challenge, by some of the work that we had done prior. For example, about 3 years before that, we had an activation of our State Emergency Operations Center. It was about 11 o'clock at night. And we're sitting in the center because there was a report of a laboratory that was found in one of the western suburbs of Chicago. And in that laboratory, it appeared to be a bio-level 4 laboratory. And we were sitting there with the director of the Emergency Operations Center. We had one of our employees who was trained because he had come in from a police background, a military background, and how to use biohazard suits. And they were entering the laboratory to try to determine what exactly was going on here. We had the FBI on the launch pad at Quantico, ready to come in and help out if we could in fact determine that this was a risk. And as we were just getting the description from our staff who was in there with signs on the wall that said, "Go, bugs, grow," all of a sudden something clicked in my mind. And had been an earlier investigation about fraud. And it turns out that this actually had been a case that the Attorney General was investigating because they had a simulated bio-level 4 lab. And that they were bringing in potential investors in this new innovation. And when I brought those together and brought it to the Emergency Management Agency at 1 o'clock in the morning, and the head of the state police at 1 o'clock in the morning, they began to realize, in fact, the head of the Emergency Management Agency said that every disaster has a public health component. So when we got to September 11th, and we began to respond, and I was sitting in the Emergency Operations Center, we knew each other's names. You never want to get into a disaster situation and exchange business cards. You want to work with people you've worked with and thought things through. The second thing that we had done to prepare for that was recognize the importance of bioterrorism as a public health challenge. Much as current public health officials and state health officials in 2017 have identified ahead of time the challenge of the opioid epidemic, and to make plans in place, and to recognize that you can't always get funded when you think you have a need, but if you explore it and put plans in place, when there's an opportunity, you can actually get funding. So we had wanted to expand our laboratory to include molecular biology. And we'd put it in our budget, and the Bureau of the Budget said no, and the governor's office said no, and we put it in the budget the next year and the same answers. And then there was an outbreak of invasive group A strep, also called flesh-eating bacteria. And it was in a small town in central Illinois. And at that point, there was a lot of news and everything. And the governor's office said, and the Bureau of the Budget said, well, what's going to be our response? And my response was, we need to expand our laboratory. $500,000 immediately became available, and we built in that molecular biology capacity. If I hadn't been ready for that answer, and I could say, this is exactly how we spend it, it would have been a missed opportunity. And we would not have been available in 2001 to have that laboratory enable us to respond to the thousands of white powder evaluations we had to do. So it's identifying where the challenges are, looking at opportunities, and then taking that opportunity when it presents itself to move forward the public health agenda.
I wasn't about to step on that line. One of the things we're looking at in our study is how the agency or people recruiting the new SHO can help state health officers to be successful early or fast. Are there some things you wish you had known when you became state health official?
Well, I was in a somewhat different position than a number of SHOs. I had been in the agency for 5 years before I was appointed state health director. And I was very familiar with a number of the people both in the legislature but also within the agency. But the challenge of coming in as a new state health official, particularly if you haven't been in the department, is you have to know the people in your agency. And you have to know who's good, and you have to know who's not good. And that becomes really important because coming into an agency, you sometimes don't appreciate the dedication of state employees and also the difficulty in recruiting people with certain credentials. One of the things I had done, and it took me a while, is I was able to recruit a PhD epidemiologist to head up our epidemiology section. It took me years to find this individual. My successor, when they came in, thought that was someone who was part of the old administration and pushed them out of the agency. And the agency still does not have a PhD epidemiologist. So it's coming into the position and knowing the importance of certain skill sets to being able to carry out the public health mission, I think, is one important thing. But for me personally, the one thing that I wish I had known more about was the Public Health Service Corps. And I came into public health out of the field of emergency medicine. I wasn't really familiar with the Corps. And I think that that is a critical national resource. And I think I would have either personally thought about being involved in the Corps or getting those officers in the Corps more involved in the work of the agency. Because times change, leadership changes, but the Corps has a certain amount of consistency that I think it can provide at the state level that it currently provides at the national level.
Great idea. Thanks for planning it. Let's talk about your departure. Agencies experience departure of state health officers, sometimes precipitous, sometimes planned. What's the impact of turnover, of departure of the state health officer on the agency and its ability to continue? When I think about turnover within agencies and turnover in leadership, sometimes that's something that's very difficult to plan for and figure out how to do in a good way. When I came into the agency, I followed Bernard Turnock. He was our state health director. He had brought me into the agency, and I learned a lot of things of what to do. In fact, the transition was a little bit strange. I still remember I was state health director for about 4 or 5 months, and I was down in southern Illinois, and we were doing a visit with the regional office, and I was talking about how we were following through on Barney Turnock's initiatives. And one of the regional health officers said, you can do your own initiatives too. And I was doing them, but it really put it in a different context that now that I was the leader. Alternatively, other transitions that I've seen, where I left, the new administration came in, not just at the state health department, but in the governor's office and throughout state government, saying, we're throwing the bums out and we're going to do everything different. Somewhere there needs to be a middle ground. And I think transitions help best if the new person coming in recognizes what was positive about the other agency and at the same time begin to implement their own ideas. Are there some things agencies can do to prepare for departure, particularly, of course, some of the more precipitous ones or even short-term state health officers. Is there something we can do to shore up the agency's resiliency to handle top-level turnover?
Agencies, I think, have a role to play in thinking about how to manage turnover in the lead person, the state health official. Some of the things that they can do is think about their operations, clearly document everything that you're doing, in a sense, the manual. So should someone new come in, it's not something you have to do. You do that during transitions. You develop a transition report when you have a new governor. Why not have it as an ongoing document so you're ready in case there is a transition in state health official? If there isn't, you're still ready if you have to do a transition report for a new governor anyway, so it helps you get that process. The second, and this is really critical for the role of the state health official, they are not all of the show. And that is an important thing to remember. If you don't function in such a way that you are delegating authority, and not just delegating authority to your tight circle, most of whom serve at will, but also delegating authority throughout the agency, so that if there's a change at the top, you've got policies, procedures, and ways of operating where people feel that they have the autonomy and the ability to make good choices, to carry out innovation. And at that point, you begin to protect the agency from changes in leadership because you build in that resilience through a strong infrastructure.
Let's talk about life as a former SHO. You've done quite well. Maybe we should talk about relationships between state public health and philanthropies, maybe building on your experience with RWJ. How can SHOs work well with philanthropies?
So let me talk about the question of how state health agencies can work with philanthropies. And it's critical for a state health official to recognize that there are many types of philanthropies. First, there's a tendency to look at large organizations like the one I work for, the Robert Wood Johnson Foundation, and say, how do I build a relationship with them? But that's not really the most critical. Every state, every region has regional philanthropies. In Missouri, there's the Missouri Health Foundation. In New York State, it's the New York State Health Foundation. These regional philanthropies, many of which were formed as a conversion from a not-for-profit to a for-profit hospital or healthcare system or insurance company, have significant resources. And they tend not to have a relationship with the health department, but my guess is predominantly because the health department has never come to talk to them. Seek out those philanthropies. In some locations, particularly the largest cities, they have funder collaboratives. Seek out those collaboratives and talk about the priorities of the state health department. And you may not get interest immediately, but if you begin to talk about the broader context of health, you may find that these philanthropies become critical partners. And they will be very interested not in funding the state health department, but funding your initiatives and funding your initiatives at the community level. So that's a partnership I didn't really appreciate when I was state health official that I've seen now from the other side and would say that's a critical approach to take in thinking about engagement between state health officers, state health agencies, and philanthropy.
Give me a pep talk for people who are former state health officials about ASTHO and ASTHO alumni. What difference can we make?
So one of the important questions for state health officials as they're thinking about the end of their term is to think about the broader health context and how you are positioning yourselves. Just as I talked about the role of the state health department is to create the conditions in which local health departments can be successful. In many ways, I look upon that as the role of the CDC and other federal agencies in creating the conditions in which state and local health departments can be successful. and they don't always get it. Part of the role of a state health official is to not only work within the state, but to think about the broader national context and to be engaged not only with things within your state, but also nationally. And that means in a couple of ways. One is by working with ASTHO. ASTHO is a critical organization because it's the voice of state public health throughout the nation. And most importantly, it's the voice of state public health in Washington. Get engaged with agencies of the Department of Health and Human Services or Agriculture with WIC, because it's important for the voice of state public health to be heard there. But it's also critical to do those things as part of your own personal transition planning. When you think about your next step, the first thing people do is begin to network. And it's very similar to the situation in a disaster. A disaster is not the time to share business cards. And when you're looking for a job because there's a change in administration or because there's been some disaster it's time for you to leave, that's not the time to begin to exchange business cards and think about your next job. Carrying out your job as a state health official, networking within the state but across the nation, also positions you to have an environment in which you can begin to network and think about your next position.
And once you're in the next position, can you continue to advance the cause of state public health?
I think it's really critical for state health officials, once they've left their position as a former state health official, I think it's absolutely critical to not give up the fight. That what you've experienced is something that only a small number of people have experienced. It gives you an insight that only a small number of people have. And it is your responsibility to carry that insight with you into your next position and the position after that. And that means thinking about how, whether you're working in a healthcare entity or a government agency or even in philanthropy, how you can carry forward what you've learned and continue to build the public health mission. Public health cannot be successful solely by itself. It can only be successful with building those partnerships. And once you leave that role as a state health official, you can help build those partnerships in your other position. And then finally, it's absolutely critical. I found one of the things that have been most rewarding is working in the ASTHO Alumni Association and having the ability to continue to interface with my colleagues in current shows. It's made me more successful in my job, but it's also been more fulfilling because, again, it's a club of which there's very small membership, and not everyone understands what you've gone through, but they do.
So I'm having a great conversation with you, John, and thanks for making the time. But I didn't want to miss the opportunity to hear your vision of what's next on the horizon, next exciting challenge or opportunity for public health.
When I think about the next exciting challenge for public health, I'm really struck by what we're doing at the Robert Wood Johnson Foundation and the concept of building a culture of health. That has really been exciting for us, but I think it should be exciting for public health writ large, but also for state public health agencies. It begins to put in the context of what we do in public health. And every time I work on this, I think back to 1996. We were involved in Illinois in an initiative related to reducing infant mortality in Grand Boulevard. It's a very poor community on the south side of Chicago. At the time, 60% of the people who lived in that community lived in large conjugate public housing. And we went to talk to them about infant mortality. And they wanted to talk about economic development. And we said, we're the public health agency. We don't do economic development. We do infant mortality. And we went round and round, and all of a sudden it was this aha moment. The leading risk factor for infant mortality is poverty. And we were not listening. I once had a professor when I was training in emergency medicine who said, if you listen to the patient long enough, they will tell you what's wrong with them. And in public health, if we listen to the communities long enough, they will actually tell us what needs to be done. And so we took that program in infant mortality and we hired peer case managers, people from the community to be case managers. We set up a WIC program where we went away from the normal WIC stores where there's fraud and abuse, and we set up a system where people could go in there and the WIC coupons were good at the stores, and we hired people from the community to run these WIC-only stores. And we set up arrangements whereby once they were trained in the WIC-only store, they would then be hired by the large chains. And we merged and used our public health dollars as part of economic development in the community. And as this broader concept, a broader way of thinking about how we in public health can engage this broader concept. And that is really where excitement comes. And we think about health impact assessments, and we think about working with businesses and transportation. And all of a sudden, the public health vision becomes so much closer than it's ever been. If that isn't exciting, I don't know what is.
I'm with you, John. This is your bully pulpit. Anything else you want to say to particularly a group of new or incoming shows, because this video will be viewed by them, I know. Any last words of wisdom for the new class of shows?
So if I were to give a message to someone who is this new state health official, having told them how they need to work with other agencies, how they need to work within the agencies, how their funds are going to be restricted. This is the best job in the world. This will be some of the best times of your life. Take time to pause, to enjoy the moment, and to recognize the importance of what you're doing and how rewarding this can be. Because it's too easy to focus on the challenges and too easy to focus on the problems and that senator who's been giving you grief. But think about what you've been doing and what you can do. And that, I think, is really the joy of this position.
So I conclude that your professor of emergency medicine was right. If you listen to John Lumpkin long enough, you'll get an insight into what you need to do. Thank you, John. This was just wonderful.
Thank you.